Good afternoon, everyone, and welcome to our webinar. Before beginning, I want to start with the land acknowledgements. My name is Verna McGregor. I'm usually the Elder McGregor, and I usually give the land acknowledgement on behalf of the Algonquin Nation. So I wear two hats today, but I'll just give you the standard also text from also Ottawa acknowledging our territory. So because Ottawa is built on our unceded Algonquin Anishinaabe territory, and the peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia. Their culture and presence have nurtured and continue to nurture this land, and we would like to honor the peoples and the land of the Algonquin and Anishinaabe Nation. We would also like to honor also too as well all First Nations, Inuit and Métis peoples, their elders and their ancestors, and their valuable past and present contributions, including to the discussion today. So anyway, so again, my name is Verna McGregor. I say Kweka Kina, Vernon Indishnikas, Kitagonzi Binindonjapa, Walkushnidodem, Shichunim Kipanesi. I'd like to welcome you to our unceded lands, and I always talk about the significance of Ottawa for us as Algonquin people since time immemorial. We are known also too as well for the birch bark canoe. So our method of travel was by canoe. And so the rivers were our highways. So the significance of Ottawa is that you have the confluence of the rivers coming together from the four directions. And what prior to contact too as well, we would meet here and talk about what's going on the land, any issues that need to be resolved, like conflict sometimes also is sometimes a sign that there's issues that we need to discuss and maybe come up with solutions. So again, so the significance of Ottawa is that confluence. So it's interesting that we have Parliament Hill here today, and now we're meeting here today to talk about an important issue, which is addressing this mental health. So really quickly too, I also work at Minwashin Lodge, which is the Indigenous Women's Support Center here in Ottawa. And we provide services for the women and children that are leaving violence. So we have a number of services and outreach as well. So also too as well, on behalf of the co-sponsors of this event, I'd like to thank the co-sponsors of this event, which is the Ottawa Black Mental Health Coalition, the Minwashin Lodge, where I work, the Ottawa Community Partnership for Healthy Health Equity, Crime Prevention Ottawa, the major sponsor, and the Social Planning Council of Ottawa. I welcome you to our first segment of our webinar series, Responding to Mental Health Crisis, Learning from Models in Ottawa and Beyond. We're starting a journey here of learning and exploration to also address this issue of mental health. So, because we know that as a society, we need to do better to serve people facing mental health crisis. I also speak from experience as well, too, as well. It's important to note that also that the Black and also the Indigenous communities have historically been underserved and inappropriately served by mental health services. Not having good options for mental health crisis response is sadly also a matter of life and death. It is our hope that by showcasing some of the existing response options, both here and abroad, we as a society can have a better idea of how we can do better to serve some of our most marginalized family, friends, and our neighbors. I'm happy to say that we have over 400 people that have registered for this webinar series today. So hello to all of you out there. For audience participation and to ensure that confidential questions can be asked in this webinar today, we are using the Zoom question and answer function. For this event, please add your questions in the question and answer at the bottom of your screen. The question and answer portion will take place during the second part of this presentation. Also too as well, you can also access the French interpretation. You will see the little globe icon at the bottom of your screen. So again, too as well, it's just clicking on and choosing which language you choose to listen in on. And I'd also like to, as well as to ask participants also to make sure you turn off your microphones. So to get us started, I am happy, and we are happy to have Rachel present the Reach Out Response Network. So I'd like to introduce you to our speaker today, which is Rachel Bromberg. To give you a little bit of background of Rachel too as well, Rachel is the co-founder of the Reach Out Response Network. She's also the executive director of the International Mobile Services Association. And she's also a Juris Doctor and Master Social Work student at the University of Toronto. One busy lady. She also works with the Education Department at the Center for Addiction and Mental Health, providing trauma-informed de-escalation training to inpatient and outpatient staff. So we're very honored to have you here, Rachel, today to bring your knowledge and start our journey of learning. So on that note, I'm going to ask you to take it away, Rachel. Miigwech.
Thank you so much, Verna, and thank you everyone for being here. I'm so excited to talk with you guys about the Reach Out Response Network and the work we're doing in Toronto. I am going to share my screen. We have practiced this, so it should work. Awesome, it works. Okay. So I'm going to start off just talking a little bit about our organization, giving you a little bit of background. And then I'm going to talk about the crisis response pilots that are going to be launching in Toronto in January of 2022, which we're all very excited about. So, Reach Out Response Network. What is the Reach Out Response Network? It is the organization that I co-founded with my colleague Asante, who sadly could not be here today because his real job, the job that pays him, needed him. But I'm here to present. So our organization is a coalition of community stakeholders dedicated to advocating for and creating transformational change in Toronto's mental health crisis services. And we have been working with the City of Toronto to design and implement a peer and clinician-led mental health emergency service that's not a police-led or even a police-partnered service, but is led only by community members, including mental health workers, but also including, people with lived experience. So our vision and the work that we're doing is developing the service with the city. And here are just some things about the teams that we're working to build. So the teams are going to be accessible via 911 dispatch, but also accessible hopefully via 211, that's the plan, as well as through their own direct number. The teams are going to be available 24/7 across the city with rapid response times at the point at which they're completely rolled out. But this is a really important point. The teams are going to replace police response to nonviolent mental health crisis, which, as we know, is the majority of mental health crisis. So the Reach Out Response Network isn't the agency that's going to be operating the service. We're an advocacy focused nonprofit. So our job is really to give feedback to the city about what the community wants to see in this new service, as well as, we consider ourselves subject matter experts in this field. So we also do a bunch of research and share the information, what we know about best practices in this field with city staff in order to support them in developing the most robust, most effective kind of team necessary. But we're not going to be directly providing the service. So who we are. Reach Out Response Network is led by Asante right there and me. He is actually a lot taller than me. I'm very short, he's very tall. Picture is very accurate. and a group of about 400 volunteers. Um, Asante and I are both mental health advocates and also peer workers. But the Reach Out Response Network, it's not just us. We have an advisory council made up of senior leadership in mental health, 911 dispatch, policing, not police officers, but folks who have a lot of expertise in that. So for example, like our former and current members of the Toronto Police Services Board, which is the civilian oversight body for the police service in Toronto. And then we have 6 advisory panels. So that's really the bulk of the community engagement that we're currently doing. We have advisory panels made up, so we have an advisory panel specifically for Black folks, an advisory panel specifically for Indigenous folks, an advisory panel specifically for service users, an advisory panel for family members of people who have experienced mental health or substance use challenges. We have an advisory panel of service providers who are doing frontline work with these communities, and an advisory panel specifically for peer workers or peer advocates. So, genesis of our organization and also the work that we're doing in Toronto. So Reach Out Response Network, or the seed of the Reach Out Response Network, really started in late 2018. Asante and I used to work together at a youth mental health agency called Stella's Place in Toronto. And both of us have worked in the mental health field for a while. Both of us have done a lot of crisis work. And, you know, I've worked at suicide intervention services for a number of years. And one of the things that I've noticed while working on crisis lines is that often people would be calling in and they would sort of say they're experiencing thoughts of suicide, for example. And I would ask more because I would want to get an understanding of where they're at, how it can support them. And a lot of the time people would say to me, you know, I'm just not comfortable telling you anymore because I'm scared if I tell you, then you're going to call 911 and police are going to show up. And maybe they'd had bad experience with police before, or maybe they live in a community that's over policed, or maybe they just have heard stories about bad experiences people have with police and they just didn't want that to happen. And I really saw that as a barrier to people actually getting the support that they need when they're in crisis. So Asante and I talked a lot about this, and at a certain point we thought, hey, we can probably do something about this problem. This isn't just like a static thing that is completely inevitable, that exists everywhere, has always existed, always will exist. There probably are other places around the world that are doing a better job than we are at mental health crisis response. So that really led us to start to do some research into other cities and the way that other cities handle mental health crisis response. And we learned about an organization in Eugene, Oregon, which is not a city that either of us had ever heard of before, to be clear. But we learned about Eugene, Oregon, and their Cahoots program, which is a program that has been operating for 32 years now, that sends crisis workers rather than police to respond to mental health or substance use crisis calls in their community. And Cahoots, because they've been around so long, they have been integrated into city services. So they're accessible via 911 dispatch or the police non-emergency line. And they've been able to take a huge volume of calls. In 2019, they actually took 20% of all 911 calls across the city. So we were really excited to learn about Cahoots, and we connected with them and we asked them, who else is doing similar work? And from there, we connected with some other cities like Olympia, Washington, Denver, Colorado, some other places that had either built similar teams or were in the process of building similar teams. So that was the start of our international network. And we also started to do some research like in the literature about, what are best practices for these kinds of teams. And we started to do some networking within the city of Toronto also to sort of talk to people here to try to understand what the crisis system here looks like and where there might be opportunities to make this kind of change. And also how, Eugene, Oregon is a city of fewer than 200,000 people. So we sort of figuring out like, how could we scale the amazing work they're doing there to work effectively in a city that is as large and diverse as Toronto is. And at the time in 2019, early 2020, our idea did not gain a lot of traction. People were not very interested. The big players in the mental health space and, in government were sort of saying, well, this kind of project it's an okay idea, but it's going to take a lot of time. It's going to be really expensive. We don't really need it. There's nothing really wrong with our current system. Everything's fine. Like, why change it? Basically, that was the response that we were getting. However, in May of 2020, after George Floyd was killed and after the deaths of 5 Canadians experiencing mental health crisis, over a period of 10 weeks during police interactions between April and June, all of a sudden Toronto, as well as many other cities across Canada and across the United States around that time, did a complete 180, all of a sudden wanted to integrate this kind of crisis team that they'd been resisting for years previously. So in Toronto, our city council passed a motion unanimously to commission a report on how to build a Kahoot-style team in Toronto. And that's where Asante and I were like, hey, we've been doing this work and this research for close to 2 years now. We have this international network of all these other cities that are doing this work also. We've done all this research. We can help you. So we officially incorporated as a nonprofit around that time, and we got a contract with the city to support them in doing some community engagement and also in putting together a report. So over, this is probably the next slide. We signed a contract with the City of Toronto to prepare a report on basically what the community wanted to see in a new crisis response service, as well as what does the research say, what are best practices internationally for this kinds of service, and then to make recommendations. So that report, if you're interested in reading it, it is long. It's 92 pages long. I wrote it. It was a very fun couple of weeks. It's available on our website, reachouttoronto.ca, if you're interested. So what went into writing that report was we held over last summer 18 town halls with a whole bunch of different communities. We had, so the first town hall that we did was with Black communities. The second town hall we did was with Indigenous communities. We also put together a survey that we distributed to, or we partnered with different organizations to distribute to the homeless population. And we did another survey for deaf communities. And we partnered with an organization that works with deaf communities to also do a town hall for them. So we really wanted to reach the communities that we thought would be most impacted by this new service, or who might have unique needs, like deaf folks, like high school students, like autistic folks, like folks with developmental disabilities. Those were the populations that we targeted, as well as Black folks, Indigenous folks, family members, service users, service providers, as well as some consultations that were open to just community members in general, anyone who might be interested and have something to say. So we did all these town halls, we did 2 surveys, we did about 150 individual interviews or key stakeholder interviews. And then we formed our advisory panels and consulted with them on what the report should say. And finally, we put together this very exciting report that we shared with the city. And they took all of our recommendations, which is very exciting, and put basically a shortened version of our report that was put in a motion to City Council that in February of this year, and City Council voted unanimously yes to build these kinds of teams, which I will talk about. This is fine. So these are some of the folks that we've been working with, different mental health organizations in Toronto or in Ontario, as well as city councilors. So one of the things that our organization did, we met with every single city councillor in Toronto, except I think one or two, just whose schedules didn't allow for it. But we met with almost all the city councillors, many of them multiple times, to really share information about these kinds of programs, so that they would be well informed when they were going into the vote. Because what we realized was that a lot of folks just have a lot of misconceptions about what these kinds of teams are or aren't, or about, a lot of people have an association in their heads between like these mental health crisis calls being, oh, dangerous, scary, person with a knife, something like that. And that's really not what the majority of these calls are. What we know from the data is that 89% of mental health crisis calls that go into 911 don't involve any kind of violence or weapons whatsoever, like no risk. So we really just wanted to share that information with city councilors and with the community in general, so that when folks are making decisions about how to vote, for example, on this motion, they're doing that from a place of accurate information rather than sort of the myths propagated by the media. So very successful. Our council passed this unanimously. We also continue to prioritize our engagement with Black and Indigenous communities in particular. And a lot of the work that we've done over the past year has been really focused on connecting with organizations that serve those populations and making sure that we're prioritizing those voices in our consultations and in any work that we're submitting or any recommendations that we're making. So City Council had voted yes to develop the new teams. Maybe I'll say a little bit about the pilots that are going to be happening in Toronto. So there are going to be 4 different pilots that are launching in January of 2022, which we're super excited about. The pilots are going to be in 4 different neighborhoods, and one of the teams is going to be an Indigenous-led pilot, specifically by and for Indigenous communities in that neighborhood. And the pilot, so basically the teams are taking the recommendations that we've made. They're going to be accessible via 911. Cities working to also make them accessible via 211 and also through their own number. The way that it's going to work, it's not going to be directly operated by the city. The city is going to be partnering with agencies in each of the 4 catchment areas to operate and deliver the service. So there's going to be a request for proposal process that starts, I believe, next month, where agencies in each of the catchment areas can apply to say, hey, I should be the one operating the service in my community. City staff are going to, the procurement department, I suppose, is within the city hall is going to determine who the successful agency will be. And then there's going to be a lot of work done in, hiring staff, training staff, figuring out like what specifically this is going to look like in that community. And then in January of next year, these teams are going to launch in those 4 different areas. The pilots are going to run for 3 years, and there's going to be an independent third-party evaluator. And for the Indigenous team, there will be an Indigenous organization that does the evaluating. And there will be annual reports back to council every year about what the progress is like for these teams. And assuming everything goes well, the hope is that these teams will be expanded on a rolling basis so that by 2026, they will cover the entire city of Toronto. So by 2026, anytime, someone is calling 911 saying, my loved one is in a mental health crisis, rather than police showing up, it'll be these teams of mental health workers and peer workers who respond instead. So, and the Reach Out Response Network is hoping to, we're going to be continuing supporting the city with implementation rollout and with further community engagement, like hosting town halls, for example. And then another thing that we're doing, so the Reach Out Response Network is the anchor agency for the International Crisis Response Association, which is basically our international network that 2 years ago was just 6 or 7 cities, including us, and now has actually grown to over 60 cities across Canada and the United States that either have current alternative crisis response teams, non-police response teams, or that are in the process of building those teams. So our association has meetings twice a month where we can talk about topics of interest and share resources, share information. We're still in the early days, so we're still developing an infrastructure. But some of the things we'd like to do, or that we're in the early stages of planning, are putting together a directory of resources and also like mapping out which cities across Canada and the US have these kinds of programs in a way that's like accessible for people, rather than it just being in my brain and everyone having to email me and be like, who's doing what where? So that's one of the things. We're also hoping to put together a longitudinal systematic research study that could follow say 15 or 20 different cities that have either recently launched these kinds of programs or will be launching these programs soon, in order to measure outcomes across cities, to really build up the evidence base for these kinds of teams. So that's some of the stuff that is happening in Toronto and internationally and within our organization. Here's our contact info if you're interested. So yeah, our website is reachouttoronto.ca, and all this stuff is on our website. If you want to read our report or other documents we've put together on our website, if you want to email me, here's my email address. Feel free to email me. And if for folks who are interested in potentially, like, if you know of work being done in your community to build a similar crisis response team, or if you want to start doing that work and you want to be connected with the International Crisis Response Association, email me. I'll set that up. Question time. Exciting. I'm going to stop sharing now.
That's wonderful, Rachel. You might take a break in public speaking here. I just got the first question that we have here is, again, and you already gave your coordinates at the end of your presentation, but somebody wanted to know too as well if the slides can be emailed after the presentation. So I guess it's contacting you directly too as well, and I'm sure you'll gladly send them out. The second question now is, will this response model be implemented across Ontario? Well, again, and is there advocacy that can happen for that? Or is that basically too as well initiated within each region?
So for our pilots specifically, they're just going to be within Toronto, not like throughout the GTA or throughout Ontario, just because the funding is coming from the city of Toronto right now. So, if folks are interested in building similar teams in their communities, like, speak with your city government about it. There are lots of cities like in Ontario that are interested in doing this work or have started doing this work. But I think to my knowledge, it's mostly happening on a local basis rather than something that will be province wide.
Wonderful. The second one that I have is, if we wanted to be part of your team, how do you apply?
Good question. So the Reach Out Response Network isn't going to be the service provider. There are going to be different agencies across Toronto that are the service provider. So once those agencies are selected, which they haven't been yet, the RFP process is going to start next month. But when they have been selected, those jobs will be publicly posted. If you sign up on our website for our email list, we'll post that stuff. Also, when that information is available, we'll share all the information about it.
Wonderful. Our next question too comes from Sarah, and she said that, how did you get this group network going and the City of Toronto staff endorsement?
Good question. It was kind of just, I mean, I don't even know how to answer that question, because it was kind of lucky in some ways. Like, it was sort of being in the right place at the right time to a certain degree. I mean, formally incorporated in May as a nonprofit, and we happened to get some media attention from the Toronto Star. We're actually on the front page of the Toronto Star, which was really cool. And when that happened, we had a lot of people who came to our website wanting to volunteer with us, and that's how our network really grew and started to gain a lot of traction. Initially, in terms of how we got city staff on board, we just reached out to them right after the motion in council had passed. We just sent an email to the people that we knew who were working on this portfolio, and we just said, like, we have done all of this research. We're interested in supporting you. How can we do that? And they were really open to meeting with us and discussing it. And they quickly realized we knew a lot of stuff and that they could benefit from that. But in terms of how folks in other cities have done this kind of thing, or what we recommend when we give presentations to other cities who want to start it, like, we usually just say, like, find a group of people who are interested in what you're doing, bring them together, start trying to get as much publicity for it as you can, and also connect with city government. We reached out to city councilors, and initially we thought this is going to be really hard, like, they're not going to want to talk to us. They did want to talk to us. Like, we got meetings with nearly all of them fairly quickly. Just reach out to your elected officials. It's not actually as scary as at least I thought it was at first. And that's really how we gained a lot of traction and respectability, I would say, like, within government, that people really wanted, and within city staff, like, they really wanted to hear what we had to say. So.
Oh, nice. We're getting a lot of questions. We have about 30 questions, and I hope we'll try and answer as many in the time frame that we have. And but one question I was looking at, here's a long question. It's from Susan Ong. She says, "Hi, Rachel. Thanks for your presentation. It's amazing. What did you tell counselors who were asking about what happens during the 11% of calls that are violent and have the potential to be violent? For example, if someone calls 911, 211, 988 and says, for example, my dad is in crisis and he has a knife, but I know he's not going to hurt anyone else, but only potentially himself, what will happen?" Can you talk to us about through the logistics of what will happen next in responding to that call?
Yeah, that is a really good question, and one that at this point we don't have a super clear answer to. Like, right now, in terms of the pilots, the police are still going to be responding to those kinds of calls. Obviously, that is not an ideal situation, and that's not where we want to end up. Once the pilots are completely rolled out, that's not the plan, that's not the goal. But initially, and this is the way that we've been able to gain a lot of, I would say, political traction or traction within our community. We have started off focusing on the low-hanging fruit. If we can say that if we know, like, from the data, that 89% of these calls are nonviolent and don't involve weapons, start there. Those are 89% of calls that very clearly do not need any kind of police response whatsoever. There is no threat, there is no risk, there is no need for an officer to be there. So get those calls away from the police first, and then let's have a conversation about the 11% and what that might look like. There are probably some of these calls that can be responded to by a civilian-only team. Cahoots sometimes does go to those kinds of calls in Eugene. It's also the case that there are some calls that might be higher acuity that might be best positioned for a co-responder model, where you have a police officer and a mental health worker or a peer worker who go out together. Again, we're still in the very early stages in Toronto. But I think, the way that we've started off in terms of our advocacy is just started off explaining, that's a very small percentage of calls. Let's focus on the majority first and figure out the difficult minority after we've already built the system that's functioning effectively for the majority of low acuity nonviolent calls.
Mm-hmm. So you have like a safeguard in place too as well. I have the next question too. One of the questions is, what are the different hypotheses being tested in the different pilots in Toronto? And are there different techniques, processes being applied, or is it just a geographic differences? An example is there a difference in terms of the indigenous, but also too as well the different segment of the populations?
So that's a good question that we're still figuring out. Our recommendation and some city councilors' recommendations was to try out some different things in each of these pilot areas. The pilots are still in the early phases. They haven't launched yet. So we're still figuring out where there might be an opportunity for some modifications, particularly based on the individual communities that are being served. One of the things that might be different, obviously the community agencies are going to be different. We're hoping that one of the pilots will be, the partner agency will be an agency that specifically focuses on serving Black communities. So that might be a difference. And one of the things that we're trying to see, as well as obviously the Indigenous pilot that focuses specifically on Indigenous communities. So, but the real answer is too soon to tell.
Yeah, I know, because I noticed that too as well, because I work in an Indigenous organization too as well, but also with the research too as well. There's a big emphasis on our workers being trauma informed, because it's understanding also our different history, even here too as well with colonization. And as other segments too have a different historical background, and that impacts sometimes the understanding when you're responding to a trauma response. I have another question now here, which is on from the Eugene, Oregon model, and it's from Michelle Brainbridge, and she's asking, if a working model has been working for 32 years in Eugene, Oregon, why has it taken so long for this to get going elsewhere?
Good question. I would say possibly because most people haven't heard of Eugene, Oregon. I would say that is probably the easy.
It's in the booties. No.
I don't know. I mean, the work that, so Cahoots now is working with a whole bunch of other cities to support them in building this model, but they only really started doing that work in 2017, I would say, and only then, like with cities that are quite like physically, geographically close to it, like Olympia, Washington, like Portland, and other places in that area. So I would say probably just because people hadn't heard of it and because there wasn't a lot of, like, I don't know, a fish swimming in water doesn't know that they're swimming in water. They don't necessarily realize that there are other things, there are other possibilities of what the system could look like. But then obviously after George Floyd was killed and after this became a topic of national conversation, lots of people learned about Eugene, Oregon who had never heard about it before. And that's, I think, when lots of cities were like, hey, we can do something new.
Wonderful. And so, and the other questions are too as well now, because you've taken a model from Eugene, Oregon. There's one question too for Ray Sullivan is, what kinds of resistance have you met when you were bringing this to the city of Toronto?
Yeah, a lot of people who hadn't heard of Eugene, Oregon and thought, Eugene, Oregon, what's that? Why do we care about them? And lots of skepticism about how you could transport a model that works in a city of 170,000 people to a city of 2.7 million people, which, point taken. It's also the case that Eugene, Oregon is not the only place that's doing this. New York City, Chicago, Los Angeles, basically our big sister cities in the US are building similar models. So that was big point of resistance in terms of showing like how you can scale this model effectively and modify it to meet the needs of diverse communities within Toronto, particularly knowing that we have a large Black and Indigenous population, and particularly knowing that we have, you know, a majority minority city and a lot of new immigrants into Toronto. And a lot of linguistic diversity, for example. So there are lots of considerations that need to be taken into account in Toronto that are not the same for Eugene, Oregon. The other big kinds of resistance people who are worried about risk of violence, who are like, just wait until the first social worker gets killed. And what we did with that, I mean, there's nothing we can really say to that that convinces the people who make those kinds of statements. In my experience, we have tried really hard to collect a lot of data on this topic, including, what percentage of 911 calls related to mental health involve any type of violence or weapons, but also connecting with the teams that already are doing this work and asking them, what is your rate of staff injuries? And the answer is always either 0 or very, very, very close to 0. Like Cahoots tells us, out of 24,000 calls they took in 2019, they had like maybe 1 or 2 at the most, like minor injuries. And that's very typical with the teams that we've consulted with. Like there have never been any serious injuries, hospitalizations, deaths of any crisis worker on any of these teams. And Cahoots has been around 32 years. So we put together a report that sort of outlined that and like created a graph and like a fact sheet. It's on our website. I don't know if people like, I don't think that us sharing all the data actually really assuages people's concerns, because it's not a concern based on fact. It's really a concern based on feeling and media portrayals and I think stigma. But that's been a big question that we've gotten. Every media appearance we do, that's the #1 question and the #1 comment on our YouTube videos or our news articles. And then the other thing is just working with the police department and figuring out how to get these calls effectively dispatched to the civilian team. That has been, I mean, the police in Toronto are quite supportive of this. Police in most cities are quite supportive of this. They know that their officers don't like responding to these kinds of calls. That's not why they got into the field. They don't want to go deal with a suicidal person. That's not what they like to do. And they know that that's not necessarily what they're good at. But just figuring out how you get those calls that right now are being answered by police to be transferred elsewhere, like that's just been a big logistical challenge.
I would think too as well the police would welcome that too as well, because sometimes too they have to go and accompany the client to the hospital.
Yeah.
And they have to wait
Yep.
and you're waiting there sometimes 4 or 5 hours because of the medical crisis, even more so with COVID-19. I have another question. I'm gonna try and include 2 questions into one. They said, was there any research done in the needs of the LGBTQ2S communities? But also, did you also consult with the youth and foster care at all too as well?
So the Reach Out Response Network wasn't the only agency that was doing town halls and community engagement for the city. So I think it was the 519 or another organization that specializes in working with LGBT communities that did town halls specifically with LGBTQ2S communities, just because they, a organization that has been working with those folks for many, many years and has already built trust with that community is obviously going to be better positioned than like a brand new nonprofit that hasn't, to do that kind of work. Similarly with youth, I'm not sure if any specific engagement was done with youth in the foster system. I know that we did some individual interviews with youth, but there were also some other organizations that were heavily involved, like the Toronto Youth Cabinet, and some other agencies that were doing engagement with youth.
Wonderful. And the other question is too, as well, is that how is this different than something like a crisis response team available through various other distress lines? How do you differ from the distress line calls?
Good question. That's a very good question. So the way that this differs is that it's going to be accessible via 911. And what we know, like having worked at a number of distress lines, is that the demographic of people who are calling distress lines and the demographic of people calling 911 for a mental health crisis are very different. So what I know from working on a crisis line is that the majority of the calls to a crisis line are made by the person in crisis themselves. Maybe 10, maybe 20 at the most % of calls are what we would call third-party calls, where it's a family member, a friend, or someone like that who's calling on behalf of the person in crisis. What we know about 911 calls related to mental health crisis is that only 16% of those calls are actually made by the person in crisis themselves. About 30% are made by family or friends, about 30% are made by service providers, and about 25% are just made by, bystanders in the street who are seeing something happening and they're like, oh, okay, this seems like there's something wrong, probably should call 911. So that a lot of the calls that are going into 911, like by bystanders or by service providers, are just not, those are not people who are ever going to call the distress line. So if there is a team that's only accessible via the distress line, the people are not going to know about it. What we also know from the community engagement we did, especially with family members, is that they were telling us, first of all, that they don't know other numbers to call other than 911. They also told us that in a crisis, they might have known that there were other services, like, for example, in Toronto, the Gerstein Center that offers a mobile crisis line. But in that moment of crisis, they didn't remember that that service existed or what the number of that service was. Or they knew that the service existed, but they didn't call it because they were like, well, what my loved one really needs right now is police, ambulance, hospital, even if that once that response arrived, they were like, don't think that's actually what my loved one needed. So the difference is really that we're trying to divert police calls at the source. Right now, Toronto Police, last year, they took 33,000 mental health related calls. And that's not mental health plus crime, mental health plus violence. That's like just straight mental health, including about 11,000 suicide related calls. Those are calls that are going into 911 that are not going into the distress line. So we're trying to get those calls away from police and instead send them elsewhere, divert them at the source.
The other one, I have another question too, as well as if funding could come from Ottawa, would your organization be willing to facilitate the setup here? Also, did you set up meetings with the councillors in Toronto, or was it through the advocacy orgs? Also, another question I'll tie in there too, as well, is where did your funding come from too?
Okay, hold on. Those are a bunch of questions. Where is that question in the chat so I can find it and follow it?
Okay, I'll just repeat it. It's way down. If funding could come from Ottawa,
yeah,
would your organization be willing to facilitate the setup here, which I think you probably would? Or
yeah,
also, did you set up meetings with the councillors in Toronto, or was it through the advocacy organizations that did that?
So we are the advocacy organization. So we set up the meetings with the city councillors in Toronto. And we also encourage like folks within our network to also set up their own meetings, write to their councillors. What we found is that city councillors and like MPs, MPPs are like really happy to meet with you and to talk about this topic. So we just tried to reach out to as many people as we could, and it worked out well. And yeah, if you would like some support in developing something similar in Ottawa, reach out to me. Let's talk.
I have another good question. Will the agencies partnering with the pilot programs make a commitment to not call the police and cut partnerships with the police?
That's a good question. The honest answer to that is probably not.
Probably not. It was
highly unlikely. What I am a pretty pragmatic person, I'm going to say. That's sort of the attitude that I take to this kind of work. What we've seen with Cahoots and also with other services is that, like I was saying, 911 integration for this kind of model is essential if you want to divert these calls at the source, if you want to actually not just create an alternative to police response, but actually remove and replace police response. You have to be able to get the calls through 911. For that to work effectively, because in most jurisdictions, and in Toronto specifically, 911 is currently operated by the police. you have to have some kind of relationship with them and some kind of trust built with them. That's what we see also with Cahoots and with Olympia, Washington. When they started their team, they had their crisis workers like just walking around with police for I think close to 6 months, like training with police and like seeing the kind of work that police were doing before they started to go out on their own, because they wanted police to sort of know them and see them and understand like that they are competent and skillful at responding to these calls. And initially police were very skeptical and didn't want to hand over these calls to the crisis response unit. They were like, who are these guys? They're just like hippie social workers. They're not going to be able to handle any of these calls. But then when they started getting to know them and seeing them handling the calls, they were much happier to sort of let them have the calls that the police themselves did not want to deal with. They were impressed and surprised. All that to say, if you want these teams to work effectively, you need to have some kind of friendliness, which is a yucky thing to say. I don't like saying it, but you need to have some kind of friendliness with the police department if you actually want to get rid of them taking the calls.
Which just leads into the next question that was asked here too as well is, should there be a special unit in police services trained in such interventions and dedicated to attend such events? That is, only willing, trained, and ready police officers would be involved? Or really, is there special training for the police too as well? Do you see special training for the police and to act in tandem with you too as well?
Yeah, so that kind of model already exists in Toronto and in a lot of other cities, either as a co-responder model where police will go out with the mental health worker to respond to calls, or like a CIT model where you have specially trained police officers that can go out and provide a response to these kinds of calls. I personally, because I'm pragmatic again, and people can feel free to disagree on this, I personally think that this kind of program, it probably most realistically operates on a continuum where you have the lower acuity or even the medium acuity calls that just straight off go to the civilian team. So you've got your 89% of definitely nonviolent calls, maybe another couple percent that just automatically go to the civilian team. And then you have a co-responder model, in my opinion, where you have specially trained police officers who can respond to higher acuity calls where there might actually be a risk of violence or harm to someone other than the person themselves, where a civilian team might not be comfortable going out alone, where the civilian team might, or the civilian on the team might still take the lead in terms of de-escalating. But you never want to be in a situation where your civilian team might need to ever use like physical force against someone. You don't want to be creating a situation in which your civilian team is doing like mental health act apprehensions or anything like that. You really definitely don't want your civilian team to ever be doing physical restraints on anyone. Like you just don't want your civilian team to be touching people without their consent ever, because that destroys trust. If you're in a situation where like someone is acting very violently and some kind of physical restraint or force might need to be applied, you don't want your civilian team going alone to that, because that destroys trust with the civilian team.
And then that goes back into now the next question too as well is, do you think that connecting this to 911 will still create issues of trust, and people might still have concerns that police will arrive when they call, when they use 911?
Yeah, so that's why we really advocated strongly for multiple access points so that people can avoid calling 911 if they don't want to call 911. Like our hope and our strong recommendation was that the calls could be diverted from 911, but people could also access them via 211 and could also access them directly by calling the agency themselves if they want to. If they want to be 100% sure only the agency staff are coming, they can call a direct number and say, hey, I want to make sure that Cahoots or whatever comes out. It won't be called Cahoots, but I want to make sure that this team comes out, and I don't even want to go through the 911 dispatch service.
I have the next question is more for, I think, too, as well, even Indigenous communities or even rural communities too, as well as how could these forms of mobile crisis response programs be scaled to more remote communities?
Yeah, that's a good question. And there are some smaller municipalities, like Northampton, Massachusetts, for example. It's like 20,000, like pretty smaller places that are building similar teams. There are different considerations that come with smaller communities, just like, large community. The problem is, how do you integrate effectively? How do you serve all of the people that you need to serve? And like diversity, smaller communities have different challenges, but it definitely can be done. It's really just focusing on talking to the community. What do they need? What do they want to see? And also mapping out where are the assets that already exist in your community? Who is already doing this work? And how can you capitalize on that, on the skill sets that folks are already bringing to run this team effectively?
Hmm. My next question, going back here, is the service would be good in high needs neighborhoods, particularly where there's a high population of Aboriginal, colored, Black community members live. Have you had the opportunity to work with community associations, and has your organization done the appropriate cultural competency assessment to meet the needs of the ACB communities, the Aboriginal, colored, Black communities?
Yeah, so our organization did a bunch of town halls, and we have our advisory panels, but we are actually not the agency that's taken the lead on communicating or like doing engagement with folks of color, and particularly Black and Indigenous communities in Toronto, just because we are a very new nonprofit. There are other organizations that have been serving these communities for many, many years and have built a lot of trust over that time. So, for example, Taibu, which is a community health center that specifically serves Black communities, they took the lead on a lot of the cultural competency stuff and the community engagement for Black communities. And obviously, Indigenous organizations took the lead on community engagement with Indigenous folks. So, like, we have done some of that work, but we are certainly not. We would never say that we are like the key players in that work in Toronto, just because we're a lot less established than other agencies.
We have so many wonderful questions, but I'm going to, we're at 12:55, so this is one of the last question. I want to thank the audience for all their wonderful input, and you as well. Uh, Rachel, I think you did a wonderful job, but also the last question is, first, it's from Anonymous. It says, thank you for your presentation. What, according to you, the cases of mental health crisis have increased tremendously since COVID started compared to pre-COVID. What have you
Yeah.
seen?
In terms of the increase of these calls?
In calls, yeah.
Yeah, so we know from 911 call data that mental health related crisis calls have increased substantially. And also, we know from the community agencies that we're working with that they've also been overwhelmed with high volume of calls, particularly crisis lines, particularly like the Gerstein Center and their mobile crisis team. They have received a much higher volume of calls. So that really shows that there's a gap in our community, and I mean, in many communities also, in not having the resources to effectively support people through global pandemic that is, lots of people are experiencing elevated mental health crisis or challenges because of that.
That's good. So I think that's what we're going to do is we're going to, it's 12:56. We're going to wrap up unless we want to include one more question. Other than that, I think the harms of BIPOC communities. There's maybe one more little question here. It says, how is this program addressing the harms BIPOC communities have raised with social workers and the violence they create too? The connection to social workers.
So that was a big question that we asked in our community engagement. We really wanted to know from community members who they wanted to see on their teams and who they trusted. We were surprised that the majority of folks and the majority of Black and Indigenous folks did want mental health clinicians on their teams. And we actually were unsure whether our data was reliable on that. But when we supported the city in doing a much larger survey, we found very similar things. However, because this has been a topic of some contention, basically what the city of Toronto ended up doing was sort of punting to the community agencies that you'll remember haven't been selected yet, who is going to work on the team. So basically they have sort of left it a little bit open in terms of who the staff are. They've specified, it'll have to be people who have substantial training and significant, like the ability to do this kind of crisis work, but they haven't said, like, is it going to be social workers? Is it going to be mental health nurses? They basically said the community agencies themselves can determine who those staff members are. And I think the hope, particularly for Black and Indigenous communities, for the Indigenous-led pilot, and then the pilot they're hoping will be led by a organization that specifically serves Black folks, that the folks who are working on those teams, or the roles that are selected, will be roles that are trusted by those communities. So that's the hope.
So thank you very much, Rachel. I think you probably need a good glass of water by now with all the talking that you did, the wonderful information you've spread. I want to thank you for sharing your information here today. For those of you online too as well, I know we talked about cahoots a lot. Well, Rachel talked about cahoots a lot. Just to let you know that we're going to be having another event on May 19th, specifically on cahoots. The other events that are coming up too as well is on May 5th, we're going to have the Edmonton Crisis Response. And then on June 2nd, we're going to have Minwash and Lodge come in and talk about their crisis response here in Ottawa. So we look forward to the audience out here joining us again. And before I leave too, I want to say miigwech for coming out, sharing your questions. Rachel, miigwech for sharing your knowledge. I want to remind the people who are online too as well that we also have a survey, an electronic survey at the end here. So it's going to show up on your web browser when this webinar ends. So please fill it out. Crime Prevention Ottawa appreciates your input, and it guides their future presentations. So again, to Azila, I'd like to say miigwech to everybody. It's the start of our journey of exploring addressing mental health. So I say thank you. Miigwech, merci. À prochaine. We'll see you soon.